Now this is a very interesting X-ray of the chest. Now this is an AP view. Now what I want to show in this X-ray is there is complete white out of this left lung field. Now the left lung field, if it is completely white out, there can be only two possibilities. Either the patient has a gross pleural effusion, or the second pathology is collapse of the lung. Now, how to differentiate or how to understand? It's very easy to remember that in collapse lung, it will be almost always sudden onset. It means ki most of the time, whenever the patient is intubated or whenever the patient is admitted in the hospital, the we usually do one or two or three or four x-rays. So the first, second, third x-ray may show this type of lung which is well aerated, which is well radiolucent. But if some patient has this type of lung and suddenly it goes completely like white like this or radio like this, it means that the patient has developed collapse, because in few minutes, few hours, the patient won't develop this much of pleural effusion suddenly. So we have to understand this one thing, that lung collapse can develop suddenly. The second thing, in lung collapse, the most common pathology for lung collapse is the lung collapses because the secretions which are coming through the lungs, they are actually drained from the bronchi or bronchus or bronchioles. So if these secretions they get impacted in the bronchus or bronchiole, the air cannot go out at all. The air cannot go in as well as the air cannot go out. So it will get collapsed completely and it will appear dense white or radio opaque like this. Now, why would someone have complete blockage of the mucus plug? Or why would someone's bronchi get completely blocked? It's very easy. Anytime when the patient is intubated, we need to understand the endotracheal tube. Here we can see that if you focus on this area, this is basically endotracheal tube. You can see the margin of this. I'll clear this thing so that you can again see. So very thin, there is basically, you just trace this, you just focus on this. This is basically endotracheal tube. So this is the endotracheal tube, which actually has to be above the level of T4. What is T4? Is thoracic fourth vertebra, because this trachea bifurcates at the level of carina to give right main bronchus and left main bronchus, and then it divides further to lung parenchyma. So just imagine that some patient is intubated. This is the main trachea, this is right and left. So what actually happens, we should always intubate and put the tube around 3 to 5 centimeter above this carina, means the tube should come up to this, so that whatever air goes in and goes out should be present at this. But what commonly happens, if mistakenly, if this endotracheal tube is put down up to the right side, so what happens to left? The left side, nothing can go out, because this is almost completely blocking the airway, because you have inflated the balloon here, so nothing can go out. So whatever secretions are there from left side of the lungs, they are going to get blocked in the left main bronchus. They are not going to go out, because the tube is placed like this and you have completely blocked this way by cough. So these secretions, they cannot pass through this, because here we have all is tube. So the secretions get impacted here, so air cannot go in and mucus cannot go out. So this lung completely gets collapsed, and it will be seen as sudden deterioration of patient's saturation, because one complete lung is not functioning, not getting aerated. So what you see, it's sudden worsening of saturation, sudden worsening of the patient's saturation, and complete radio opacity. So we need to always remember the T4 level. Now how to remember the T4? You always remember one thing, The clavicles, at the level of clavicle, you usually have a T2 vertebra. So below than that, T3 and T4. So this is the limit where the trachea bifurcates into right and left bronchi. But what, and that is the reason why we should always put a tube, and the tube should come up to this level, around 3 to 5 centimeter above the carina. But in this case, what has happened is, you can see that the tube has come long way to to this, up to here. So it is going down. You just see this, this is the basically, this is the tube, this is the tube. If you can very nicely see, it is very crystal clearly we can see, this is the tube, this is the tube basically. This is the lining of the tube which we can very crystal clearly see. So that is the reason why it is completely blocking left side of the lung. So left lung is not aerated. At the same time, the mucus from the left lung is not suctioned outside. So it is blocking and causing all radio opacity of the left lung. So sudden onset of this whiteness or radio opaqueness of the lung with worsening of the saturation or oxygenation clearly tells us about lung collapse. The treatment is very simple. You simply remove the tube, or you just drag the tube outside by around 2 to 4 centimeter also. So it will give space for all this suctioning of the mucus. And if it is not possible, then bronchoscopic removal of the mucus plug helps and can completely cure this problem. And when we do a next x-ray, we can see that this lung which was completely radio opaque has now opened up, and now will be looking like this. That's all for now, and thank you.